Our next topic is about hepatitis C, where also there's no vaccine, but there is a cure. And the presentation is by Associate Professor Gail Matthews. Gail's in the viral hepatitis clinical research program at the Kirby and also has a clinical appointment at St Vincent's Hospital. Gail's leading a range of research in HIV and viral hepatitis, co-infection, but today he's going to speak to us about striving towards hepatitis C elimination in Australia. Thank you, Gail.
Thank you, Beck. I think one thing that's become really clear over the last couple of days and listening to all the tributes about David is what a truly broad individual he was, and he was broad in his thoughts and he was broad in his actions. And although HIV was clearly David's main passion throughout his career, he also cared deeply and was deeply committed to our work against other infectious diseases and in particular against hepatitis C. And he was greatly supportive of our campaign towards hepatitis C elimination. So my job in the next 15 minutes or so is to really tell you where we are in Australia and why Australia is really leading the way globally in terms of hepatitis C elimination, and maybe reflect a little on how that has been shaped by the HIV response in Australia that David was so much part of. So I think almost everybody in the room would be aware that the WHO for the first time in 2015 released some global viral hepatitis elimination goals to be achieved by 2030. And these, although actually more correctly control goals rather than true elimination, were certainly incredibly ambitious, but have given us a framework to work towards. And they include a reduction in the number of new cases of hepatitis C of 80%, a reduction of 65% in liver-related deaths, testing to go to 80%, and treatment to go to 80% by 2030. Now, the Polaris Observatory keeps a global map of the countries on track to meet these targets, which changes regularly. And I'm pleased to say that Australia is one of the few countries there in green, and it has been in green since the start, and we intend to keep it in green until the end. So let's just look at the framework, I guess, that has allowed us to stay green to date in Australia and where we have got to so far. So you can see on this graph that in the days of interferon, our treatment numbers of hepatitis C per year were tiny. They were less than 1% of the population. And it wasn't until we had the government-funded access program for DAA therapy that we started to achieve amazing results in terms of hepatitis C treatment numbers. And you can see there that in 2016, treatment numbers up around 30,000, slightly less so in 2017, as we might expect, and I'll talk a little bit about that in a minute. But overall, it means that we have treated around 60,000, and I should say cured around 60,000 Australians living with hepatitis C in those 18 months, and that is really a phenomenal achievement. Now, the reason why that has been able to be achieved is clearly in part related to the availability of drugs. So the directly acting antiviral agents we have, incredibly effective, very easy to take, and through the Australian government-funded program on the PBS, we currently have 6 regimens, including last year the pan-genotypic regimen of sofosbuvir, velpatasvir, which has given us the key to really start talking around the elimination issue. Now, later this year, we also hope to have 2 more regimens, the Mavriat regimen, which is also pan-genotypic, can be given for 8 weeks only in people without cirrhosis, and importantly, the Vosivir triple salvage regimen. And this will allow us to treat and rescue the few people who have failed the original regimens, and really provides us with the tools to treat pretty much every person with hepatitis C in Australia. Now, having the right drugs is clearly a very important aspect, but is not all you need to do to achieve elimination. And there have been key features of the program that Australia has developed, which the rest of the world is really looking to in terms of what we have done. So the features of that program are universal, unrestricted DAA access for everybody who comes forward for treatment. So that is no cap on treatment numbers, and there are no restrictions by fibrosis or drug or alcohol use as there are in many countries. A really novel and innovative arrangement between government and pharma was reached in 2015, which allowed us to treat patients for a very reduced cost compared to the typical cost of these regimens. So we estimate approximately $10,000 per treatment course it costs through that risk-sharing arrangement. And there's been really no other arrangement to date like that globally, so it really was a very innovative step. Another innovative step, and going back, taking from the HIV experience, the involvement of non-specialists in DAA prescribing has been key to allow large numbers of patients to be treated. And I think Australia really took this on board because of that unique situation in terms of the S100 HIV prescribers who were so willing to come on board and start treating, and the model of care was already there. The programme also has minimal administration for clinicians and a minimal payment for patients, so it was really simple to put out. In development, we can look at how it's followed some of the aspects of the HIV response. So a framework, the National Hepatitis C Strategy, clearly based on the National HIV Strategy, which is now in its 8th rendition. The bipartisan support, you've heard a lot about that today in terms of the HIV response, bipartisan support and political leadership and the will to get this done. And a partnership approach from government, again, really strong involvement from community, critically important from clinicians and from the academics, all coming together to want to achieve this goal. Funding of hepatitis C and drug user community organisations. We've heard about the importance of those earlier today in terms of HIV, but critically important also for hepatitis C. And general practitioner education for hepatitis C since the early 2000s, building on that S100 HIV model. And this has been really successful. So if we look here at the increasing involvement of non-specialists in prescription of DAA therapy, in purple there you can see the GP prescriptions per month, starting off at a very small number when the programme opened, but then for our most recent data, now making up almost half of the prescriptions written each month for hepatitis C therapy, and that's an amazing achievement, and that needs to continue. And again, it's something the world is looking to Australia to see how that has been done and how that will continue to go. So that's a great program, but we need to constantly have a look and see what we're doing, what we're managing to achieve. And we need to really look at data from key populations. So firstly, in terms of that goal around reducing the mortality from hepatitis C, for this we really need to look at patients who have cirrhosis. These are the patients who are at risk of dying. And what you can see there is on the bar on the right-hand side is the treatment uptake in people with cirrhosis as compared to the rest on the left. And what you can see there has been massive targeting, quite rightly so, in the first instance to those people who have cirrhosis, so that we now estimate 70% of those patients have now been treated and cured of their hepatitis C. In terms of, if you look at the other end of the WHO goals, those goals around reduction in incidence, for that you have to look at the key populations at risk for hepatitis C transmission. And those are populations, people living with HIV, people who inject drugs, prisoners, etc. So we have, and are starting to collect through Kirby particularly, but also other surveillance systems, data on what is happening in these populations. The first data comes from the annual needle and syringe programme, which Lisa Marr heads in the Kirby, and shows incredibly encouraging data. The graph on the left showing the uptake of DAA in people who inject drugs taking part in this survey has mirrored that within the general population, so certainly it's getting into this group of people. And as a result, in that first year, HIV viremic prevalence has fallen by a third, from 45% to 32% on the next round of surveys. So this is really encouraging data to suggest we're getting to the populations that really need it. Prisons, another population where it's critically important we put out hepatitis C treatment on a systematic basis to try and eliminate transmission and prevent it going back out into the community. And this is some data from Darren Russell's programme in one of the prisons up in Queensland, showing that with a consistent effort to treat prisoners there with hepatitis C, they have reduced the prevalence from 12.6% to just over 1% over an 18-month period. And many other prisons in Australia, again, now taking up this model and working with it and doing similar things. And in the co-infected population, this is data from our study looking at what is happening. This is a cohort of around 20% of the co-infected population within Australia. And uptake in this population has probably been at the highest across all communities, partly because many of these patients are engaged in care and their prescribers are engaged with the process. So here we see viremic prevalence falling from 80% in 2014 to as low as 18%. In 2017, and we're continuing to follow this cohort, and we're hoping to demonstrate that this group will be one of the first to achieve what we call micro-elimination, and this is going to have a major impact on new transmissions in the HIV community. There are challenges ahead, undoubtedly, and you can see here the prescriptions by month clearly have dropped off after the first 6 months or so. Not surprisingly, there were many, many patients who were warehoused and waiting for treatment, if you like, and the clinics were overblown with patients, flat out treating patients for those first few months. Now, prescriptions have reduced since then. They seem to have levelled out, and we'll be keeping very close eye on this data in the months to come. I think it's important, though, before we will get too downcast about the fact that the treatment numbers are going down, to realise that modelling work will tell us that even in a pessimistic scenario, shown in red there, where treatment numbers per year drop by 40% each year, we will still reach the WHO goals of elimination as set by 2030. So we shouldn't be too pessimistic. But we do still need to keep on track, and there are some very important things that we need to do to do that. The first is to continue to look at our health systems and the way that we are delivering DAA to patients that need it. So the traditional model of the tertiary hospital treatment setting and even the primary care setting are not enough. We need to use different models of care. We need to take the treatments out to where these patients who are often marginalised in our community are and treat them out where they need to be treated. We need to keep everybody engaged in the movement forward. I think there's been a lot of sort of a feeling, oh, well, hepatitis C is done now. We can forget about it. It's all done. Of course, it's not done. We've treated only 25%. We've got another 75% of people to go, and we've got one of the highest in Australia records of treatment. So hepatitis C is far from over. Enhanced hepatitis C diagnostics are very important, as I said, to get to the communities affected, and that means looking at novel methodologies, including point-of-care testing for RNA, and there's a number of different programs going on within Kirby and elsewhere to look at how those test and treat and linkage to care programs might develop over the next decade. We need to increase DAA treatment numbers in prisons and in communities of people who inject drugs, for example, at needle and syringe programs. This is a perfect place to put a test and treat program in, and these models need to be looked at carefully. Non-specialist involvement is encouraging, but larger numbers of prescribers are needed, and we need to understand who the prescribers are now and how to engage more prescribers as we move forward. Community awareness campaigns are important. We actually know that most of the people who have hepatitis C in Australia have been diagnosed at some point in their lives. We need community awareness campaigns to encourage those patients to come forward, to let them know that there are treatments available and to enhance linkage to care. And I think something that David knew very much in terms of when he set up the Kirby or NCHECA is the importance of monitoring and evaluation of what you are doing if you want to achieve something consistent in the end. There are many different sort of models of care for hepatitis C, and I was fortunate enough to be the convener of the first Australasian Viral Hepatitis Elimination Conference last year, and it was a conference of so much energy and so much enthusiasm from all sectors of society, and it really speaks to the fact that once you give people the tools to go out and treat patients, they will find ways to do it that suit their community and their setting. So community centres, vans going out to places where patients are, working with peers and the community affected, novel methods, dry blood spot testing, point of care testing, etc. All of these different models can help engage and get us to where we need to be. Finally, just to mention, as I said, evaluation is incredibly important to keep us on track and to keep guiding us and making sure we're achieving what we want to do. And there are many different programs, many of which are coming out of Kirby, but not all. Some of these are coming from other places such as Burnett as well, but different evaluation programs to understand how and what we're achieving and what we need to change as we move forward. I'm going to finish there, and I think this is hepatitis C elimination in Australia is a really very good news story and a very exciting thing to end on. I want to just acknowledge that it's a story that involves many, many people from many, many sectors, and they have all come together and worked incredibly well in collaboration. I do just also want to acknowledge, especially though for a couple of reasons, Greg Dorr, who is not here today, he's overseas. Firstly, because it is his passion, just as it was David's for HIV, that is really driving a lot of this elimination agenda. But secondly, really because I think Greg would be the first to acknowledge the impact that David's mentorship had on his own career journey. And we've heard a lot today, I think, about the amazing ability David had to mentor individuals such as Greg and also myself and all the other people you've heard speak today. And I think it's an amazing legacy that he leaves, that there are a new generation of clinician researchers going forward, not just in HIV, but in all kinds of different paths. Thank you.